So, hello, everybody. My name is Dr. Matthew Lafrenière. I'm a clinical biochemist at Sunnybrook Health Sciences Center in Toronto, Ontario. And the title of my talk is Autoantibodies and Myositis, Clinical Importance and Current Laboratory Methods for Detection. The overall learning objectives today are to describe the etiology, risk factors, and clinical presentations for idiopathic inflammatory myopathies, to describe the methods used in the detection of autoantibodies associated with these myopathies, and to describe the advantages and disadvantages of each of the detection methods that can be used in idiopathic inflammatory myopathies. So I'm going to start us off with kind of what are idiopathic inflammatory myopathies. So they are a rare heterogeneous group of chronic autoimmune diseases of skeletal muscle that can affect both children and adults. And generally, they are characterized by muscle weakness and inflammation. And manifestations can range from arthritis to myocarditis, dysphagia, rash, Raynaud's phenomenon, interstitial lung diseases, amongst several other manifestations that are possible, and various subtypes of myositis, and each subtype has a different spectrum of target tissue. So, by way of example, idiopathic myositis predominantly affects skeletal muscle, whereas dermatomyositis is multi-organ, which can affect lung, skin, and joints. Now, overall, the incidence is estimated to be about 8 cases per million, which is, again, quite rare. And generally, the frequency of myositis phenotypes can vary. Dermatomyositis has a frequency of between 35 and 50% within the inflammatory myopathies across the board. Polymyositis about 30 to 45%, and sporadic inclusion body myositis tends to be about 10 to 20%. And on average, the age of onset in adults is about 44 to 55 years of age. And I will highlight that generally there's a greater proportion of females than males who develop myositis, with the exception of sporadic inclusion body myositis, which tends to be associated with males. So there are several risk factors that are associated with myositis. So the Myositis Genetic Consortium study of about 2,500 mostly European patients has highlighted a strong association with polymyositis and dermatomyositis with an 8.1 ancestral haplotype. There are non-HLA risk factors as well, like STAT4, TRAF6, and UBE2L2. And have been reported kind of environmental risk factors that are associated with these inflammatory myopathies. So, for example, co-occurrence with HBV has been associated with polymyositis, and HCV has been associated with sporadic inclusion body myositis. Now, what are the subtypes of myositis and their specific clinical manifestations? And what I will highlight here, as indicated on the slide, is that there is a substantive amount of debate around subtype characterization and classification. And so I will highlight those that are known, but by no means is this presentation going to focus uh, on the detailed and nuanced components of the debates associated with these classifications and these subtypes. I will just highlight some of the clinical manifestations that are associated with the myositis that we know of. So the general clinical presentation for these myositis, they tend to be non-specific, like muscle pain and weakness, and muscle weakness and inflammation. And elevations of creatine kinase or aspartic aminotransferase may be seen in myositis, but they're by no means diagnostic. So, because if you don't see the elevation in CK or AST, that doesn't necessarily mean the patient does not have some form of a myositis. Now, muscle involvement may be suggestive of polymyositis or inclusion body myositis, and skin manifestations in the absence of muscle involvement may be suggestive of an amyopathic dermatomyositis. And I will highlight here that some of these presentations are non-specific, so certainly kind of ruling out infections and other types of inflammations, malignancies, endocrine disorders, or toxic exposures is something that should also be on a differential. Now, for dermatomyositis and polymyositis, they are generally progressive with mild to moderate proximal muscle weakness. Skin findings are generally absent for polymyositis with moderate to severe muscle weakness. And common symptoms associated with dermatomyositis may, for example, include difficulty using arms if they're elevated, inability to rise from a seated position, or difficulty climbing stairs. Now, 5 of the most affected muscle groups, for both these myositis would be things like hip flexors, hip extensors, hip abductors, neck flexors, and shoulder abductors. And the rash, particularly in the case of dermatomyositis, may include the face, neck, torso, fingers, and you may also have the presentation of a heliotrope rash as well. And you can also have extramuscular manifestations such as fever, weight loss, and pulmonary and cardiac manifestations in the context of some sort of polymyositis. Now, in the case of inclusion body myositis, so it generally presents with asymmetric proximal and distal muscle weakness. So we end up having, so some of these patients will have atrophy of the forearms, finger flexors, and quadriceps. There'll be no myalgia generally in these patients, and dysphagia tends to present in less than 10% of these cases. And inclusion body myositis, as I previously mentioned, tends to be something that has a greater association with males than females, and so it typically affects men older than 50 years. And you can have either a sporadic or hereditary inclusion body myositis. Uh, Immune mediated necrotizing myositis is associated with severe weakness, can be either acute or subacute spreading to the distal muscles and dysphagia. Respiratory muscle involvement is common in these patients, so that would be dyspnea. It is associated with cancer and other connective tissue diseases. And the autoantibodies that tend to be associated with IMNM would be HMG-CR and anti-SRP. Now, in immune-mediated necrotizing myositis, the 2017 ENMC criteria includes kind of an anti-SRP and anti-HMG-CR detection as kind of a serological criteria. But I'll highlight, as I've kind of briefly mentioned, is that the absence of an autoantibody um, does not necessarily rule out the presence of some sort of myositis. So as you can see in this slide, you can have antibody negative IMNM, where a muscle biopsy would be necessary in addition to kind of a clinical component as well. So certainly the diagnosis of these would include not only a serological and biopsy, but also a clinical criteria as well. Antisynthetase syndrome can be seen in both dermatomyositis and polymyositis. It's rarely seen in inclusion body myositis, and it tends to be associated with tRNA synthetases and anti-Jo1 autoantibodies, and it is associated with ILD and lack of clinical response to corticosteroid therapy. And so the general clinical presentation for these, as you can see on the right-hand side of your slide, would be fever, rash. You can expect to see, in some cases, interstitial lung disease, arthritis, mechanic hands, and Raynaud's phenomenon for ASSD. So, how are myositis clinically classified? There's a variety of clinical classifications which are available. I'm going to focus really just on one, which is the EULAR ACR clinical classification, but there are others that can be used, but I am going to focus solely on the EULAR ACR classification criteria. So ULR ACR is focused on defining kind of the minimal features, which are both kind of clinical and pathological, to distinguish idiopathic inflammatory myopathies from mimicking conditions, but also to distinguish major subgroups of IIM. And so, how this process worked is that they used a probability score model to classify patients among a group of patients with and without uh, myositis. And so there were kind of generally three subgroups that were identified. So dermatomyositis, which would include amyopathic and juvenile, polymyositis, and inclusion body myositis as well. And I'll highlight here that within the EULAR-ACR criteria, for example, anti-synthetase syndrome is not included, but there are others, classification criteria like Connors or Solomon criteria, which include those. So by no means um, does EULAR-ACR highlight some of the other types of myositis that I highlighted in the previous few slides. This is just one of the major classification criteria that are used. So for the EULAR ACR classification criteria, so it is based both on whether there is a biopsy or whether there is not a biopsy. And so in this slide, you can see kind of the variable and then the points associated with whether there's a biopsy or not a biopsy done. So by way of example, age of onset when it comes to symptoms. So if the patient's over 40 in the absence of a biopsy, they would obtain kind of 2.1 points. And so there are several other variables like muscle weakness, skin manifestations, clinical manifestations, laboratory measurements, and muscle biopsy features, each of which, if they are present, is associated with a specific score. And so I'll highlight that the aggregate score of around 5.5 with a biopsy would be indicative of a myositis. In the absence of a biopsy, it would be about 6.7. And I'll highlight here that in the laboratory measurements, really only anti-Jo1 is used as as a as a as an additive to the scoring process, even though there are multiple different types of autoantibodies that are used. So what autoantibodies are relevant in myositis? So it's useful to highlight that autoantibodies are broadly classified into two groups. So there are myositis associated autoantibodies, which can be observed with other connective tissue disorders, and myositis specific antibodies, which are associated with various myositis subtypes. And each major subtype each clinical subtype can be associated with a specific myositis specific autoantibody. So by way of examples, we can see in this slide, dermatomyositis is associated with MDA5, SAE1, NXP2, for example. Polymyositis tends to be associated with an SRP or JO1. Sporadic inclusion body myositis tends to be associated with CN1 alpha or CN1A rather. And so it's useful to point out that there's limited crossover between the myositis specific autoantibodies and their clinical subtypes. It tends to be reasonably minimal. So if you have a myositis specific autoantibody like MDA5, that tends to be associated with dermatomyositis. So in this table highlights several myositis-specific autoantibodies, their their clinical utility, as well as the relevance. So by way of example here, SRP, for example, is associated with kind of severe treatment-resistant myopathy. Um, uh, or MDA5, which could trigger screening for ILD. So, depending on the autoantibody that is present, that can be associated with some sort of clinical condition, which may, some sort of clinical condition that is associated with a specific myositis. So, how are myositis autoantibodies detected, and what are the advantages and disadvantages of each method? And I think to start this off, it's going to be useful to identify what methods are actually available for the detection of these autoantibodies. And so that brings us to this slide. So there are several different methods that are used for the detection of not only myositis-specific autoantibodies, but myositis-associated antibodies. So this survey, which was done by the Myositis Assessment and Clinical Studies Group of about 530 members, um, identified some of the common methodologies used for the detection of these autoantibodies. So on the right-hand side of your slide, what we can see is the different colors are associated with a specific methodology. So by way of example, line blots would be in the blue, dark blue. Red would be kind of enzyme immunoassays. Green would be laser beads. Purple would be immunoprecipitation. So there is still a wide variety of methods that are used for the detection of these autoantibodies. Now, what's useful to highlight here is that in this survey, around 86% of members who responded to this survey said that the results of the autoantibody testing influenced their clinical decision making. Additionally, about 81% used those results to do further investigations. So if there was a specific autoantibody that was associated with interstitial lung disease, there may be additional testing done to assess whether there is a risk to that patient. And 73% use the results to recommend treatment. So the salient feature here of the survey is that the results of these myositis-specific autoantibody testing, or even associated myositis-associated autoantibody testing, it does have a clinical impact based on this survey. And so understanding the methodologies will give us a understanding of the advantages and disadvantages, which we can then communicate to the physicians when supporting their clinical decisions when they have these types of patients. So laboratory methods for myositis. So one of the methods that can be used is immunoprecipitation, where we have a cell lysate, or in this case, kind of a patient sample with a protein of interest. Um, these kind of, again, proteins of interest can be our myositis autoantibodies. We add antibodies that can bind and incubate. Then we add an AG beads, which will bind to our proteins of interest. And then that will form a complex, which we're able to wash and elute, and then subsequently purify to then identify using Western blot the specific myositis autoantibodies, so MDA5 or SRP or what have you. Other laboratory methods can be either a competitive ELISA or a sandwich ELISA. So in a competitive ELISA, we have kind of our antigen-coded reagent well, where we can have the antibody from our patient sample or a biotin-labeled molecule, where in the absence, or rather in the presence of these compounds, you can have, or pardon me, the antibody is present in the patient sample, that will block the antigen-coded will block the antigen, and as a consequence, you will not have a color reaction that will result. So here, the signal would be inversely proportional to the presence of the antibody. In the sandwich ELISA method, if we have an antibody-coated reagent well, that can be one of the autoantibodies associated with the inflammatory myopathy. So again, MDA5 or SRP. And then you have an antigen from your patient sample. This is all done in one step, where you then add your capture and detection, or rather your detection antibody, and you see a colored complex. So in this case, the signal will be proportional to the concentration of the antigen in the patient sample. Line blots and dot blots can also be used. So in this case, we have a membrane which is attached to or rather an antigen that is attached to the membrane. An antibody is added that will bind to that antigen, and then a capture antibody is then, or rather a detection antibody is then added, which binds to the capture antibody here in blue, and then some sort of compound is added so that a color reaction can be observed. And there are various advantages and disadvantages to line blots and dot blots broadly. So the advantage here is that it is multiplexed. It's objective rather than subjective. So subjective methods, which we'll see shortly, can be in direct immunofluorescence assays. It can be quantitative or semi-quantitative. It is susceptible to automation, or it can be automated and consequently can go through a high throughput process, which shortens the turnaround time and generally can be cost effective because you can multiplex the detection of multiple autoantibodies in one run. The disadvantage of these methods is that there is a lack of sensitivity, so there can be false negatives. There's a limited number of available antibodies. There's can be significant intra and inter-assay variations. There are different antitypes and antigens depending on the vendors, so the results may not necessarily be comparable between one vendor and another. And there's a generally there is a lack of standardization. So an additional laboratory method that can be used for the detection of autoantibodies is indirect immunofluorescence assays, where there's a biochip that has a substrate of interest, where the antibody from the patient's sample can bind, and then a detection antibody is added where there's some sort of reaction that occurs, usually a fluorescent reaction. And the advantages of an IIFA method are that the antigens are in their native form, which is kind of can be dissimilar to the line immunoassays. There can be unknown autoantibodies that can be detected, though this can be rare. It has a higher sensitivity relative to the line immunoassays. You can have additional screening for or expansive screening for autoantibodies, and again, so you can discover new autoantibodies as well. Though the main advantage of IIFA is that the antigens are in their native form. The disadvantage is that there is a high false positive rate because there's a bit more background, and there's a greater chance that the antibodies in the patient sample can actually bind non-specifically to components within that chip. It does require significant training, given that the interpretation is subjective or can be more subjective than a line immunoassay. It may be difficult to validate and verify the assays. Analysis can be time consuming. Reflex testing may be necessary, which is to say that if additional confirmatory testing is required, that may increase the turnaround time. And there is a general lack of standardization for these assays. And this is just an overview of kind of an expected, or rather, an image of an IIFA method used for the detection of inflammatory myopathies. So this would be an IFA using HEP2 ANIS slides that have myositis specific autoantibodies embedded. And so not only do you see kind of the fluorescent signal, but there are specific patterns associated with some of the myositis autoantibodies. There are emerging methods that can be used. So, for example, particle-based multivariate technology. Currently, it's only research-based, but here each analyte is bound to a paramagnetic bead that has kind of a unique color code, and each unique color code allows the identification of the analyte in the method. And each of these paramagnetic particles can be isolated and identified using two LEDs. So usually LED identifies the bead, so which autoantigen is attached to that bead, or which autoantigen rather is attached to that bead. And then the second is used to determine whether that antigen is actually that autoantibody is present, so whether it's bound or not bound. And again, this is currently being used on a research use only. Now, there are kind of conventional techniques that I've just highlighted. So the main one being uh, protein immunoprecipitation or immunoprecipitation generally. I'll highlight here that kind of conventional methods tend to be restricted to research labs because they are labor intensive. They do require trained personnel. They generally have longer turnaround time. Multi-parameter methods like line immunoassays or dot blots tend to are more easily available because they increase the efficiency. Though there is an increased risk of false positives, multi-parameter methods like line immunoassays or dot blots are also can be more useful in clinical laboratories because there's less hands-on time by the tech, which again kind of increases the throughput and subsequently the turnaround time. So, what are some kind of contemporary issues with laboratory methods for detecting myositis autoantibodies? So there's generally kind of four issues that are associated with kind of current laboratory methods that certainly need to be considered when not only verifying or validating a new assay, but also when communicating with physicians. So, for example, not all assays demonstrate the same specificity to autoantibodies. Given the IIM subsites, and there's also kind of variability across commercial assays. So it's important to note that because different methods are used for across different manufacturers, there may be issues with the positivity from one assay, from one methodology to another, rather from one commercial vendor to another, given the differences in methods for the commercial methods used. There can be issues with concordance between commercial assays and conventional techniques. So comparing kind of immunoprecipitation, which would be kind of considered a de facto reference method with commercial assays. So just because there's positivity with your line blot doesn't necessarily mean you may observe positivity with your immunoprecipitation or vice versa. So that has to be considered if you're trying to verify or validate a line blot or a dot blot against a more traditional, quote unquote, traditional method like immunoprecipitation. And like I just briefly mentioned, so there are differences between antigens on various commercial assays, which may impact the degree of positivity compared with another commercial vendor. So to conclude, there are several clinical forms of myositis, um, and there is still some ongoing debate associated with the types and the classification of these. Myositis specific and myositis associated autoantibodies are present in patients with myositis. So if there's a myositis associated autoantibody with clinical symptoms associated with a different inflammatory disease process, that needs to be investigated as well. And there are multiple methods that exist for the detection of myositis, and care has to be taken that all factors have to be considered when implementing. So to ensure the clinical teams are aware of the advantages and disadvantages. And so with that, thank you so much for your attention, and I hope you found that presentation useful.